So good afternoon, everybody. Uh, Today's topic, I'll be dealing on the basis of a case study, a very commonly asked, very frequently asked case study, be it for your Neet PG or your INICT or FMGE. Very frequently you would have encountered this. So let me just read the case study for you. A 3-year-old boy born in a consanguineous marriage had global delayed development and was unable to speak or walk properly. He was found to be having intellectual disability with seizures and tremors. His skin and hair was hypopigmented. The mother gives a history of foul smelling odor of the urine. On investigations, the boy had a plasma phenylalanine level of 30 milligram per deciliter. I've given the reference range here, that is 1 to 2 milligram per deciliter. His urine was tested positive for a ferric chloride test, which indicated an elevated excretion of phenyl pyruvate. So looking at the history, what do we think is a probable diagnosis? So we know that the child is born from a consanguineous marriage. So what does this tell us? This tells us that this is a genetic condition. And what are the conditions we encounter through a consanguineous marriage? The most common of this is phenylketonuria, which has an autosomal recessive inheritance pattern. So like you all know, autosomal recessive, so out of 4 children born to the parents who are unaffected carriers, 1 child will have the condition, 2 of them will be carriers, 1 child would be unaffected. So this particular child has been affected by this condition, and there is a global delayed development by which we know there's mental and physical retardation in this child. The skin and hair was hypopigmented, which is a classical feature of this condition. Plus, the mother gives a history of foul smelling odor. So all this history would lead us to the inborn error of metabolism, that is phenylketonuria. Now, what is this phenylketonuria? This is the condition which is affected 1 in 10,000 live births. In India, the range is about 1 in 18,000 live births, probably due to the decreased number of screening what we do for the newborn babies. So this is the most common condition we see with regards to the protein metabolism. Like we know, phenylalanine is an essential amino acid which gives the non-essential amino acid, that is tyrosine. Both these are the aromatic amino acid. What is the enzyme which catalyzes this conversion is the phenylalanine hydroxylase. Now, phenylalanine hydroxylase can be defective in a class of patients who have this disease that's called as the PKU or the classical PKU or phenylketonuria, like we see in this particular child. So what happens next when this enzyme is defective? Like if you are going on a road, there is a traffic jam, what do? We try taking an alternate route. The Google Maps are not working. We might not reach the required destination. We might just go through alternate routes or shorter routes, but we will not reach our destination. Same thing happens here. There is a block, that is phenylalanine hydroxylase is blocked. Tyrosine is not formed. What accumulates is phenylalanine. It has to take some path. It has to take an alternative path. What happens next? It forms phenyl acetate, phenyl lactate, phenyl glutamate. These are called as the ketones. That's why the name is phenylketonuria, because ketones are excreted in this condition. So why do we see this classical presentation of hypopigmentation in this child or in this group of children is because tyrosine is the one which gives us the pigment melanin. So if there is reduced melanin content, there is the pigmentation reduction in the skin, the hair and the iris of these children, which resemble a group of conditions which is called as albinism. But what is the difference here is between albinism and phenylketonuria, you see the neurological symptoms which is lacking in albinism. Why these neurological symptoms, or what is the biochemical basis for this? Because tyrosine is also important in the formation of the catecholamines mainly dopamine, like we know it's a neurotransmitter. So reduction in dopamine can cause the complaints or features of seizures and tremors in this group of people. So that's why we see the neurological symptoms, we see the hypopigmentation. So this is very frequently asked. Why is there, or what is the biochemical basis for hypopigmentation or the neurological manifestations in PKU? Now, the mother gives a classic history of foul smelling odor. What is this odor we see in PKU? The classic odor is called as the musty or the mousy odor. So normally the child might present at a very early age where the mother is changing the diaper of the child and she says that there's a strange smell. Now in this child it's about 3 years. The diagnosis has been done a bit late, but she has picked up this classical feature of a odor in the urine. Very classic of a protein metabolism error. So why do we see this? Again, a question frequently asked. This is due to the accumulation of one of the phenyl ketone, that is the phenyl acetate. So phenyl acetate is going to give the mousy odor. So you might get phenyl acetate, lactate, glutamate as were the options. So the correct option or the right answer for this is the phenyl acetate. Okay, now what is the test we do to confirm the diagnosis? Normally in the Western countries, they do a screening test. Now, what is a screening test? Screening test is done for all the newborns, irrespective of a history or previous history or presentation. Every newborn is subjected to the diagnosis of PKU. That is, we take a heel prick, we take the dried blood from the heel prick and is subjected to tandem mass spectrometry. Now, tandem mass spectrometry is the choice of test which is done for all the inborn error of metabolism. So, TMS is the choice of diagnosis here. And what are the other tests we can do? A simple test we can do with the urine of the child, what is called as the ferric chloride test, which is not sensitive. That means some other diseases also you might see this positive, but a very simple test which can be done. What is the color we get? Very classic, that is a transient blue-green color. What do we mean by transient? When we add few drops of ferric chloride to the urine of the child, we see a sudden change. That is, the color changes to blue or green. But that's only for a few seconds and it comes back to the normal. So this is a positive ferric chloride test. Again, which is done, not a confirmatory diagnosis, but yes, it can tell us that the child is having phenylketonuria. Okay, what is the treatment? What do we do once this child has been diagnosed? So this group, it better picked up early. That's why the screening test. So in Western countries, they pick it up early so that if they are diagnosed, they can be put on treatment immediately. What is the treatment of choice here? Very simple. Give the child a low phenylalanine diet, restrict the diet, and give the child more of tyrosine. High tyrosine, low phenylalanine diet is the treatment for, one of the treatments for PKU. Okay, genetic gene therapy is on the way for PKU, but this is a trick. One more important thing that has to be cautioned in this group is taking of natural sweeteners, that is aspartame. Aspartame, if you could see, in most of the natural sweeteners, we get aspartame. Now, aspartame is made up of aspartic acid and phenylalanine. So, they wouldn't be knowing they'll be having phenylketonuria. So, they take this natural sweeteners and they might end up having the vomiting or other features of phenylketonuria later in life. So, that is one thing which has to be avoided in the group of patients who are having phenylketonuria.